Hi everyone. Today I'm going to speak about other beta-lactam antibiotics. We have seen about penicillin and cephalosporin. Also, beta-lactamase inhibitors we have seen till now. So I'm going to talk about other beta-lactam antibiotics. Those are carbapenems and monobactams. So what is the difference in carbapenems and penicillin and cephalosporin? Do you know any structural or whatever difference it is? You have the structure. Sorry?
The carboxyl chain or CO bond is
Okay. The major difference is in cephalosporin and penicillin, there is a sulfa group here. So that is the only difference between carbapenems and other penicillin and cephalosporin. Also in monobactam, you can see there is no fused ring here along with the beta-lactam structure. So that is the major difference between the other penicillin and cephalosporin and carbapenems and monobactam. So there are four different carbapenem examples. They are imipenem, meropenem, ertapenem and doripenem. So these different drugs are based on the structures or the chemical molecules present in R3, R2 and R1 group. So I'm not saying about all that. So this is one thing. And one more thing is imipenem comes in a combination with cilastatin. Cilastatin is a renal dihydropeptidase inhibitors. So what exactly happens is imipenem get degraded by this renal dihydropeptidase inhibitors. So that is why we have to give imipenem along with the cilastatin so that the bioavailability of the imipenem is more. Okay, this major things about the carbapenems and this monobactam. There's only one drug present right now in the market, that is AZTREONAM. So the major difference is the AZTREONAM covers only gram negative bacteria, that is aerobic. It won't cover gram positive. Also anaerobic it won't cover. It's a very narrow spectrum antibiotic. Carbapenem has a very broad spectrum and activity. It covers a major microorganism, except the thing is it won't cover methicillin resistant staphylococcus aureus. That is one thing which you have to note. It also has a very good activity against pseudomonas, also enterococcus. I'll talk about that. So yeah, the general thing which you have to note about the carbapenems are that it is a bactericidal. The major elimination is a renal. Major elimination is renal. Also, there is a chance of hypersensitivity reaction, like otherwise, like even in penicillin and this cephalosporin, there is a chance of hypersensitivity reaction. One major thing is seizure risk. There is a chance of seizures when a patient is given with the carbapenems. That is one important thing which you have to note about the carbapenems. Basically, it is given on the hospital acquired drugs. Usually they are resistant to penicillin or other cephalosporins. Usually that time we use it. So in our hospital they usually use meropenem. If you see in ICU, they use more. So it has an excellent activity against streptococci, methicillin susceptible staphylococcus aureus, Haemophilus influenza, E. coli, Klebsiella and Serratia, and non-pneumococcal streptococci as well. Regarding AZTREONAM, it has a very good activity against Enterobacter. Okay, so Enterobacterius and Pseudomonas aeruginosa, and it has like no activity against gram positive, also anaerobic bacteria. Then we'll see about the dosage regimen. So usually I'll ask you one thing. There is it has a very good renal elimination. This carbapenems, also ertapenems. So is dose adjustment required when in a CKD patient, when the creatinine clearance is very less or something? Dose adjustment is required or not? Yeah, okay. So that's the thing. Ertapenem, usually it is given 1 gram IV every 24 hours. That is 1 dose a day. If you see imipenem, meropenem and doripenem, they are given 500 mg IV every 6 to 8 hours, usually 8 hours. Meropenem in case of meningitis, it is given 2 grams every 8 hours. So you see that imipenem, meropenem, the dose is TID compared to ertapenem, that is once a day. It is because the ertapenem has 85 to 95% of protein binding. That is why the level of ertapenem will stay longer in the blood. So that is why the longer dose frequency is there. And in case of renal failure, that is in case of creatinine clearance less than 30 ml, 500 grams, 500 mg every 24 hours we have to give. So in case of hemodialysis also, we can give 500 mg every 24 hours. Also the imipenem, in case if the creatinine clearance is less than 20 ml, 250 to 500 mg every 12 hours it has to be given. In hemodialysis also, 250 mg every 12 hours we have to give. So that is important. When a patient is on under hemodialysis and all, we have to check if the dosage adjustment is done properly or not. That will be our role in case of these drugs. And also meropenem, if the creatinine clearance is 25 to 50 ml per minute, so we have to give 1 gram or 500 mg every 12 hours. So 4 hours increase we have to do, I mean the dose frequency adjustment we have to do. Also if the creatinine clearance is less than 10 ml, we have to give 500 mg every 24 hours. In case of meningitis, we have to give 1 gram every 24 hours. The same thing in doripenem also. If the creatinine clearance is 30 to 50 ml, we have to give 250 mg every 8 hours. If it is between 10 to 30 ml, we have to give 250 mg every 12 hours. So it's little complicated. I think if I send you this flowchart or the photo of this, you will have a more clarity. It's even difficult for you to understand or listen to this right now. So yeah, even the AZTREONAM has a good renal elimination, so even that has a dosage adjustment requirement. So usual dose is 2 grams every 8 hours, but in case of creatinine clearance between 10 to 50 ml, it should be 2 grams every 12 hours. And if it is less than 10 ml of creatinine clearance, 1 gram every 12 hours. Even in hemodialysis patient, we have to give 1 gram every 12 hours before the hemodialysis and 1 gram after the hemodialysis. Yeah, that is about the dose adjustment. And yeah, that's the things which I have to say. It's done already.